So next is thyroid toxicosis. Thyroid toxicosis or overt hyperthyroidism. It occurs due to inappropriately high thyroid hormone. How is it different than the term hyperthyroid itself? Is thyroid toxicosis actually shows that there's already action on tissue, different organs, secondary to the elevated thyroid hormone. Hyperthyroid is just a state of increased thyroid hormone level, synthesis and secretion by the gland. The causes of thyroid toxicosis, there are four main causes. One is where there's an excess in production, let's say in Graves' disease, toxic adenoma, toxic multinodal goiter, or there's an increased release in conditions, autoimmune conditions like Hashimoto's thyroiditis, infective subacute thyroiditis, or if there's, let's say, cellulitis of the overlying skin over the thyroid gland, or an insult to the gland itself with a rapidly growing anaplastic carcinoma. So that increases the release. Stimulation. The thyroid gland is stimulated by other hormones or other stimulants as compared to the TSH. So thyrotrope adenomas, gestational trophoblastic diseases. That's why in pregnancy as well, sometimes you can get hyperthyroidism. Or taking in iodinated contrast material, or amiodarone itself. Amiodarone has iodine in its preparation. Or thyroid toxicosis can be caused by external sources. External sources here means extrathyroidal causes. So it can be either endogenous or exogenous. Endogenous stroma ovari, metastatic component of the thyroid carcinoma, while exogenous are thyroid hormones taken over the counter. I think there are many available now. We can actually purchase it online. Some use it as a product to lose weight. So they believe that by taking thyroid hormone, they can lose weight. Supplements, certain supplements contain they contain iodine in their supplements. And food product, I think there was a case report whereby a burger, an outlet selling burgers had triggered an thyroid toxicosis among its patrons because there were iodine, the patty was contaminated with iodine. So if, let's say, you see a patient and you suspect hypothyroid, what should you do next? So the next best thing to do would be to measure the thyroid levels. We'll start off with measuring TSH and F4, free thyroids in T4. If the TSH is low and the T4 is high, the patient has overt hyperthyroidism or thyroid toxicosis. Or if, let's say, the patient has normal T4 and low TSH, you need to measure T3. If the T3 is elevated, then it's overt hyperthyroidism. If the T3 is normal, then it's subclinical hyperthyroidism. Subclinical hyperthyroidism, just as a summary, it means that the TSH is low, but you have normal T4, T3. Next, in terms of diagnosis, you can send thyroid-specific antibodies, thyroid receptor antibodies. There are specific biomarkers to diagnose Graves' disease. So you can either send TB2 or TS1. TB2 only reports the presence or absence of thyroid receptor antibodies, their concentration, but it does not indicate whether they are actually working as a stimulant or as a blocker. Because your thyroid receptor antibodies can be either a stimulant or blocker. If it's a blocker, it causes hypothyroidism. If it's a stimulant, it causes hyperthyroidism. Yeah, or it might turn out to be neutral.